Awesome. Okay, I'm going to keep an eye on the waiting room, but we are going to get started on time. Welcome, everybody. My name is Shirley Weir. I am the founder of Menopause Chicks, in case we haven't met yet. I want to start out by saying thank you so much for putting your own name at the top of your to-do list tonight and for joining us for Say Goodbye to UTIs. And we've got somebody with their mic on, and I don't know why that's happening, but I am in a hotel and I might have just hit the wrong setting on Zoom. Who knows? I'm in a hotel because I'm going to one of my first in-person meetings right after this. And I had to make sure that, I was in proximity. So everybody, you can see me on screen, and hopefully you can see Dr. Colleen McDermott, who is joining us. I've got a few housekeeping notes to go over, and then we're going to dive right into our conversation with Dr. McDermott, because I know what an incredible opportunity it is for us to have this time with a urogynecologist. And I know that you also have lots of questions, so we will stick around for a Q&A at the end. So welcome. Colleen was just asking about some of the events that we do at Menopause Chicks. So I just wanted to remind you that the next masterclass is on May the 15th, and the next edition of the Vagina Dialogues is on May 26th. And you can find those links in the Menopause Chicks community. I was thinking today about all of the gaps in healthcare. It started out, by waking up and learning that it is Wear Red Day today in honor of missing and murdered Indigenous women. And I was thinking about the In Her Words .ca study. Some of you will know I participated. You can find the information on that study at inherwords.ca. But basically that learning, comes to this work that we do every single day. And that is a reminder that women, particularly aged 51 and over in British Columbia, where I live, they're walking away from their doctor's appointments feeling dismissed and disappointed. And that number is even higher for Indigenous women and women of color. And it kind of goes both ways in the conversations that we have every day. We live in one of the best countries or best continents, if you're joining us from the United States, for healthcare. But at the same time, we have this gap in women's health. And then once we get into the women's health conversation, there are all of these topics that continue to come up. And UTIs is one of those conversations.
Go ahead.
If you could turn your mic off, please, that would be great. UTIs is one of those topics that I'm just learning about. When I started Menopause Chicks, I was really focused on sleep deprivation and mood changes. And then you all wanted to know more about vaginal dryness. So we dove into that. And in the last year, thanks to our host tonight, UTIVA, I have been learning so much about urinary tract infections and the impact.
Why I can't get one side.
Okay, I think I just need to pop into my settings. Sorry, everybody.
What side do these go?
Sorry about that. Colleen, I may have to ask you to turn your mic on when we jump in, but I obviously must have just hit a setting earlier. Okay, so UTIs impacting our health, impacting the health of our mothers and our grandmothers, and really impacting and putting such a strain on our healthcare system. So that's what we're going to be talking about tonight, the gaps. I want to throw some statistics at you. I was, really grateful to be able to work with UTIVA at the end of last year on some research with the Menopause Chicks community. And we found out that 73% of our members have had a urinary tract infection, and 16% had had one within the last year. And then when we started promoting this event, so many of you popped into the comments with your stories about reoccurring UTIs, and particular stories about your mothers, your mother-in-law, your grandmother, your older sisters. And so part of tonight's goal, in addition to all of the education that we're going to be able to receive from Dr. McDermott, is to also hope that you walk away with some script tips so that we can take this and have conversations with all of the women that we love. Now, if it's okay with you, I want to start with a story, but first a reminder. Please stick around to the end, because at the end of our Q&A session, UTIVA does have 2 surprise gifts for us. And I'll tell you at the beginning of the Q&A how you can qualify to win those. I wanted to start with a story because it just came up a couple of weeks ago. I was going through, that bin of photos that you have underneath your bed from before digital photos. And what I found in that bin was my mother's medical records. Now, she passed away in 2008 at the age of 80. And when I reflect back on her final years, I remember extremely dry eyes, extremely dry mouth. Oh, and this was funny. She was diagnosed with dry eye syndrome. And I remember when she came home from the doctors and she's like, well, I could have told him that. Like, think about how many times we walk into a health appointment with a concern and walk out with an answer, but then we're like, what, really? And there's nothing that could be done. At least that's what she was told. It was also recorded in her medical records about reoccurring UTIs, but no evidence of antibiotics or medications for that listed. Now, in my mother's final years, she was diagnosed with dementia. And my sister and I rallied around and got her the care that she needed. And when she passed away, we ordered an autopsy. And I will never forget when the coroner called us at the funeral home. We were at the visitation when the phone call came in, and he said, yeah, we didn't see any sign of brain decline or brain decay or Alzheimer's. And I just learned recently that you actually can suspect Alzheimer's when someone is alive, but it's not actually confirmed until through an autopsy. So that had me thinking, wow, so what was, all of these dementia-like experiences that we witnessed and that my mother experienced? Was it an interaction with other drugs that she was taking, or was it a reoccurring UTI? And of course, I will never know the answer to that, but I do have an extreme privileged platform here to make sure that we can tap into the experts who do know the answers, who do know how to teach us to treat, to talk about this, and really importantly, to prevent urinary tract infections. So I wanted to share that story. Thank you for indulging me. And now I just really want to get started and introduce to you our very special guest tonight, Dr. Colleen McDermott. She is a Toronto-based urogynecologist and an expert in this space. I know some of you actually know Dr. McDermott, so that's really exciting. Colleen, thank you so much for joining us.
Thank you for having me.
I wanted to tell you while everybody was on the call, just what a pleasure it was to see that some of your patients are actually in our Menopause Chicks community.
Yeah, this is great. This is a great forum for education. So I'm very happy that I have some of my patients that are part of this. It sounds amazing. So thank you for providing this.
Yeah, can we start right at the go square? What is a UTI, and what are some of the signs and symptoms?
So a UTI stands for urinary tract infection, but we often just call it UTI at work. And this is a bacterial infection of the bladder. And usually most women will have accompanying symptoms, and it can vary. Some women will have burning when they pee, or we call that dysuria. Sometimes women can even have blood in their urine, which is a little bit alarming. Some
Right.
women can just have pain above the pubic bone that is just kind of an ache. And then as patients get older, these symptoms can change. So I always find that very interesting, because I find that younger women describe, premenopausal women will describe that classic, oh, it's burning when I pee, I'm going pee all the time, it's a UTI. And then that changes with age, and women can have kind of more vague symptoms. So it might be a little bit more difficult to pick up. They might have, more urgency or frequency, which is just a common symptom that women have with menopause and with aging anyways. They might have difficulty emptying their bladder, a sensation of incomplete emptying. They can have leakage. They can have worsening urinary incontinence. They can just have cloudy urine, or I have one patient who always says she just knows she has it because she can smell. That's the only symptom, is a change in the smell, and it's very subtle.
Oh.
Some women can even have a burning in their vagina. And then in the really elderly population, we're talking in our nursing home patients, just like you said with your mother, they might have changes in their cognition. And that can also be very subtle and difficult to pick up in a patient population where those things are kind of expected to be the norm. And I have one patient who's in a nursing home, and her family is very diligent. She comes from a medical family, and they just know by the change in her demeanor when they go to visit her. And then sure enough, they test her urine, and it is a bladder infection.
Really?
But that's the only, like, she doesn't complain of anything. So that can become a little bit difficult, because, in nursing homes, it's, asymptomatic bacteria, or when women have bacteria in their urine and they don't have symptoms, we are not supposed to treat it. And I completely agree with that. But in that population, it's difficult because maybe their symptoms are just those subtle cognition changes that we're not picking up. So it's interesting that you mentioned that about your mom. So that's basically that was kind of a big, broad definition, but there's a lot of things that it can present at. It's not always so typical, like knife in the bladder symptom.
And do we know the root cause?
So do we know the root cause? Well, we know that there's different, there's different risk factors. So we know that bladder infections are more common in young boys. So kind of in like toddler to 5 years of age boys, in older men who have all their prostate issues, and in women of all ages. So when just by the mere fact that we have two X chromosomes, we are at an increased risk of having increased bladder infections because our urethra is so short and in such close proximity to the vagina and the anus. Right. So that is our risk factor. And then there's on top of being, a cisgender woman, there's also other factors that can be incorporated in terms of there's premenopausal risk factors, and then there's postmenopausal risk factors. And so you can kind of discriminate among those two groups as well. And
so let's talk about the women category. Who specifically is at higher risk and why? You mentioned that the urethra is shorter. I've heard of younger women talking about, sexual activity bringing on a UTI. I've heard also from lots of women who kind of do a shoulder shrug as if, oh, I drew this short straw, I'm just unlucky. So who amongst us is at higher risk and why?
So again, if we're kind of differentiating between premenopausal and postmenopausal. So premenopausal, if you've had a history of childhood bladder infections, that's going to put you at an increased risk for adult infections. Family history, which is, I drew the short straw. Unfortunately, there is a genetic predisposition for getting recurrent bladder infections. Frequency of intercourse. So if there's more sex happening, then theoretically you are at an increased risk. And if your symptoms have started with a new partner within a year of your symptoms starting, that could also be a risk factor. So it could be partner specific. Also, different spermicides can irritate certain women's urogenital skin and affect their pH. And for some women, again, that just happens. So that could be a problem as well. So those are kind of the premenopausal issues. And then the postmenopausal issues, it's all of that. So those are still risk factors.
Right.
Plus the fact that you have now lost your estrogen, which is a protective piece in preventing bladder infections. So that, I know we're going to talk a little bit about estrogen and UTIs.
Yeah.
But also as we age, there's other things that are going to make us more susceptible to infections. So as we age, unfortunately, we get vaginal prolapse. And I don't know if everyone knows what that is, but that's when our vagina starts to descend, and the bladder can descend with it. So then that makes emptying more difficult. So that can predispose you to infections. Right. Women can have, as we age, we get lower back issues and spinal stenosis. So that can affect our ability to empty, which can also increase our risk of infections. A lot of women, as we get older, as we move into nursing homes, we might need a catheter here and there. We might be more prone to be going to the emergency room and getting catheterized, and that can put you at an increased risk. Having urinary incontinence and wearing wet pads, and that can also put you at. So there's just things, just by the mere fact that we're getting older, that things happen to us that also put us at an increased risk, unfortunately.
Yeah. And one of the common themes that we have in response to that is just a reminder to everyone that you're not meant to suffer. Yes. Right. So even though many of these things that we've just talked about are common, that's not sending a message to older women or women who are in postmenopause that you're just supposed to suck it up and suffer. You deserve to feel amazing. And there are things that we can do to both treat and prevent. I want to kind of jump in here though for a second. You're a urogynecologist. Here in Canada, we don't always have the privilege and opportunity of seeing a gynecologist without a referral from our GP. So most of us, if we're, suspecting a UTI, we're going to our GP or maybe a walk-in clinic. And so, what is the process for someone to get to your level, to get to your office?
How do you get to me? Yeah. So that's a good question. So the one-off bladder infection that happens, every 5 years. And just like you said, so in this group of everyone who's on, what was the stat? 76% had one UTI at least. Yeah. So, worldwide, that stat is 50 to 60% of women have had one bladder infection in their life, and 5% have recurrent bladder infections.
And we were a bit higher on that number.
Right. You were at 17%, right? Yeah.
17%,
so
yeah.
So, this is a biased group. You're here because you have I'm sure it's underreported.
We're keen to learn. We're keeners.
I'm sure it's underreported as well. I think this is from, my stats are from literature, and I'm sure it's underreported because a lot of women, as you said, just suffer. But I think that, so just as a definition, what is a recurrent, how do you get into that category of recurrent bladder infection? So a one-off is just a one-off, but if you've had, the definition is if you have had 2 or more culture proven bladder infections, meaning they have tested your urine and it has grown a bacteria in 6 months, or 3 and 12 months.
Okay.
That is the definition of recurrent UTI. And that is when you should be referred to a specialist from the family physician, to a urologist or a urogynecologist, to see if there's anything that could be predisposing you to these infections, and make sure there's nothing that's being missed.
It's an excellent piece of information for our members, and a reminder too to track it. So keep your calendar of your appointments or whatever, so that you know how to define it, because you may in fact need to be asking. for
Yeah.
additional support.
Yeah,
Okay.
and I will often ask, I'll get referrals and I'll say, I want the cultures I want to see, because also a lot of women, as I mentioned, have urgency and frequency, and that is not necessarily a UTI,
Right.
because overactive bladder is an extremely common syndrome that exists in postmenopausal women. And that's a syndrome of urinary urgency, frequency, and leakage on the way to the bathroom. And that happens in 20% of women after menopause baseline. So again, trying to distinguish between overactive bladder versus bladder infections is really important. So I will always say, I need to see the cultures. We need to make sure that this is what we're dealing with.
Right on. Okay. So do you want to do treatments first and then we'll talk about prevention?
Sure.
Yeah. So as we've said, we've just underscored, you're not meant to suffer. So what are the treatment options?
So, when someone comes to me with recurrent bladder infection, so, that's what most women get sent to me for when it's in this domain. And the first thing we will do is, I'll test their urine. So I'll try to confirm the diagnosis, and I'll give them requisitions to test their urine every 6 weeks for the next kind of 5 to 6 months. So we can kind of build a picture, a landscape of what's going on with the bacteria in their bladder. And when they're symptomatic, I'll say, please test, so I know what bacteria, I know what the bacteria is sensitive to. So if we are going to give you antibiotics, it's the right one. So I'll always start with doing that. And then we'll kind of go over some lifestyle things. So water. I know it seems so simple, but it's important. And there's actually been studies that have shown that 1.5 liters of water a day is a volume that will help to decrease bladder infections. If you're drinking 8 liters of water a day, you don't need to increase it. It's 1.5 liter is the volume. So you don't, that's what you need. If you want to drink more than that, that's fine. You'll be peeing more, but that's fine. But if you're drinking less than that, then that's a reason to increase it. And then if the patient is peri or postmenopausal, I will almost always start vaginal estrogen. So I actually saw 3 patients with recurrent bladder infections today, and that is the first piece of the puzzle. So as we lose our estrogen, as our estrogen levels start to drop, it affects the urogenital epithelium, so the skin that lines the vagina and the bladder and the urethra. And that change affects the pH in your bladder. So our bladder goes from being acidic, which bacteria hate, to slightly basic, which bacteria like. So a very simple way is to add back some vaginal estrogen.
Yeah.
And I know you guys have talked about this, and vaginal estrogen is my favorite thing, and all my patients are on it. It's very helpful for a lot of conditions that I see patients for, but particularly in recurrent bladder infections, because it helps to acidify the bladder and the vagina. So there's lots of different forms of vaginal estrogen. Usually we'll start with the loading dose. And then my maintenance is usually 3 times a week for someone who has recurrent bladder infections. So that's kind of the first thing. And then I will also always recommend a cranberry supplement. So I am a strong proponent for cranberry. There's actually very good evidence for cranberry in the scientific literature, and there's not much evidence around anything natural in medicine, but there actually is good level 1. There are 8 randomized controlled trials that have looked at the effect of cranberry and recurrent bladder infections, and it does help. So I think we're probably going to talk a little bit more about that, but so that's something that I always start. So it's kind of those 3 things to start with, and then we see how they do while they're testing their urine. And depending on if the cultures are good after they've started that, amazing. If they're still coming back with infections, then we might add something like D-mannose and see how they do. And down the line, if that doesn't work, then it might become a situation where somebody might need prophylactic antibiotics, which is not ideal, because antibiotics first of all, there's lots of resistance to antibiotics, and we want to try and avoid that. And a lot of patients cannot tolerate antibiotics. Like a lot of, it affects your GI tract. It just makes people quite ill, a lot of the antibiotics. So it's not something that we want to do, but if we have to do, then sometimes we have to start daily prophylactic antibiotics. And I'll usually keep patients on that for 6 to 12 months. And then see how they do. It's usually a lower dose once a day. Or sometimes we use an antibiotic called fosfomycin, which is a powder, and that's weekly. So depending on how they tolerate different drugs, we'll decide on that. And then after that period, then we'll have them come off and see how things evolve thereafter. So that's kind of somewhat how it flows.
Yeah, the treatment options in order. I really appreciate that. I'd actually, I was going to ask you the question, why do doctors want their patients to come off antibiotics? And then I'm looking at it now and I'm thinking, is that actually true? Do you want women off their antibiotics?
Yes.
Yes.
Yeah.
Right.
I mean, nobody wants to be on antibiotics, and it's, as I said, there's so many adverse reactions, and even in simple antibiotics, something like macrobid, I have had patients have severe complications after they've been on these things for years and years, because in extremely rare cases, and I'm talking like 1 in 50,000, it can affect your lungs and it can affect your liver. So antibiotics are not just completely benign things. And I think the goal would be to avoid that if we can. Yeah. Obviously, we want people to be comfortable and feel good and be able to live their lives. And if we need to do it, we will, and we'll monitor them. And as soon as we can get off, then we try and come off. And I've had patients who I've been seeing for years, and sometimes we're on for a year, off for a year, on for a year. And sometimes you'd have to do that. It's just trying to keep people as comfortable as possible, and as safe as possible.
Absolutely. So I've got like 3 or 4 things running through my head that I want to speak to. One is, for all of us to remember that a prescription for antibiotics might be the only thing that your GP has in his or her toolkit. So it's really good that you're here tonight, getting this information and education, because hopefully it gives you a better idea of what's on the menu of options. And Dr. McDermott, you did mention D-mannose. So can you explain what that is?
Yeah, so D-mannose is it's a simple sugar. It's a monosaccharide, and it's found in a lot of fruits. And it's thought to help prevent bacterial adhesion to the bladder. Okay. And more specific to E. coli. Cranberry has more coverage over different bacteria, but D-mannose is a little bit more specific to purely E. coli. The evidence around D-mannose is not amazing. There's two randomized controlled trials that have compared D-mannose to 2 different antibiotics. And both actually showed that D-mannose had fewer infections, but the statistics were not significant. So it's not something that you can say D-mannose is significantly better than antibiotics, because that was not shown. It was just, if you look at the numbers, it was slightly less. So it's not something that I don't throw it out there out of the gate. It's something that I might add on to. And again, it's 2 grams of D-mannose a day. So that, that's something I might see when I see them in follow-up. If they've had 1 or 2, it might be something that I add on to the cranberry and the vaginal estrogen. The D-mannose is a sugar, so it's usually not something that I'll tell diabetics to start off with, right? Because you always have to be concerned about that. And just with getting back to the cranberry, because we didn't really flush that out, but
you need to.
Not all cranberry products are equal. And I think that's, if anything, that's the most important thing that I can stress tonight. The molecule that's in the cranberry, the proanthocyanidin, or the PAC, that is the molecule that prevents the bacteria from binding to the inner lining of the bladder wall. And most of the products that we find, at Shoppers or Rexall's or CVS or Walgreens if you're in the US, that you just go and get your Jameson or your Weber brand, and it's just the cranberry 500 milligram tablets. The amount of the pack in those pills is extremely low. So a lot of the randomized trials used formulated cranberry that had high levels of these packs. So in order to reproduce those results, you have to make sure that you're using a product that gives you that amount of pack. In Canada, we have UTIVA, which is a relatively new product in the last 4 or 5 years. And it has 36 milligrams of the pack, and a lot of the studies used 30. So it's a solid product. It's the one that I will recommend to all of my patients to start off with. I know the company's done studies, and one UTIVA pill is equivalent to 9 regular pills that you'll find at the drugstore. So it's kind of, the bang is worth your buck for that pill, and something that's just important to make sure that you're getting if you are going to supplement with the cranberry product.
Yeah, absolutely. And I think we could even flesh that out a little bit more, just to make sure that, you're going to leave here tonight. Maybe you'll have a conversation with a family member this weekend. It's Mother's Day, and you're going to be talking about this great information that you've learned about UTIs, and someone inevitably is going to say, oh, it's okay, I just drink cranberry juice.
Yeah.
Right. So I'd like you to speak to that and just kind of help us understand the real significant in quality and in volume.
I mean, I say that I write it out for people, and I'm just this product, I hand them the little thing with the coupons that I have in my office. And I would say that 8 out of 10 patients still don't listen to me, and they just go to Shoppers and pick up the cranberry, or their sister picked them up some cranberry things at the health food store. And it's not the same. So it's really important that you have that discussion. As an MD, I am fully supporting this product. And I can tell you that I have seen 100% difference in my patients, because before UTIVA came to the market in Canada and we didn't have this, I would say, oh, get the cranberry products. And people would do nothing. There was nothing. And I have for the last 3 years seen such good results with the UTIVA, with patients coming back and being I'm free. I haven't had a UTI in 6 months. And with the UTIVA, especially if women have the post-coital or after sex UTIs, which are quite common, taking 2 right after intercourse and then 2 the next day has also been shown to be effective as a post-coital prophylaxis. Because, a lot of our patients who develop these symptoms right after sex will say, okay, take an antibiotic after intercourse. And this is kind of a way to defer it. Cranberry is not treating infections, but it's trying to prevent them.
Right. That's an important soundbite there.
Mm-hmm.
So what about prevention then? If, 17% of our members have had a UTI in the last year, and they've signed up for this conversation. So how can we help them prevent going forward if you're not, currently suffering or symptomatic?
Yeah. So again, just making sure you're drinking lots of water. If you don't want to take the cranberry pill every day, again, if there's something around intercourse, maybe keeping them at home, you can have it to take a couple after intercourse, and that's fine and safe. I think there's a lot of myths, or not necessarily myths, but unsubstantiated things that people that do to prevent bladder infections. And a lot of people swear by them. And I'm not saying if you feel this works for you, do it. But things voiding after intercourse. A lot of people swear that if they go pee after they have sex, it'll help prevent, and do that if that works. But that's never been proven.
Right.
Having sex with someone who's uncircumcised, never been proven. Wearing underwear that's too tight, going in hot tubs, never been proven.
Okay.
So, these are things that
the menopause space, it falls to lots of myths and misinformation.
Yeah. So I think I think just generally, just keeping yourself well hydrated. And if you are postmenopausal and you have an inclination towards having bladder infections, especially if you did in your premenopausal years, it might become a little bit worse afterwards than getting on that vaginal estrogen, which is entirely safe and will not increase your risk of breast cancer, heart attack, or stroke. Then I always tell people, as soon as I turn 50, I'm going on vaginal estrogen. So
because we need to keep our pelvic floor healthy.
You have to
for so many reasons.
I mean, I could talk to you about a million things in your vagina, bladder infections just being one, but I literally tell all of my patients to go on vaginal estrogen after menopause.
Yeah. Sidebar for our guests tonight. So in perimenopause, hormones fluctuate up and down, sometimes wildly. And after we reach menopause, we're in postmenopause for the rest of our lives. That's when estrogen goes for a steep decline. And the reason I really like to underscore that for all our members is just to make sure that you understand that maybe your roller coaster ride at perimenopause, maybe it was tolerable. But I deal with a lot of women every day who kind of wake up in their mid 50s and they're kind of surprised to learn the impact that decline of estrogen is now having on their health and their quality of life. So thank you for emphasizing that for us. Now, this is a question I have for me because I'm learning so much from UTIVA. So if I was to go to the UTIVA website right now, like I see packs and I've heard you talk about the benefits of cranberry and I see D-mannose, but I don't know, like, how do I choose? How would I decide if I was someone who is in prevention mode tonight?
I mean, as I said, as an evidence-based clinical researcher, I would always start with the cranberry and see how you do. Okay. If you've tried the cranberry and you're still feeling symptomatic or these things are popping up, then adding the D-mannose, has also been shown not as well, but to improve, can help to improve things as well. But I would always just start with the cranberry.
Amazing. Okay, I see we've got like 30 or so questions. So are you ready? Are you ready? Okay, everyone. So we have two things to give away tonight. One is a $100 Visa card. And the intention for that is to wish you a happy Mother's Day, to help you put your own name at the top of the to-do list. Maybe you want to use that Visa card if you're the lucky recipient to add another member to your health team or to go shopping online after this. And then the second surprise prize that we have tonight is 3 months worth of products from UTIVA. So we're going to go through some questions in the time that we have left, and then I'll tell you who the winners are. Okay, so I'm just going to do it in order, Dr. McDermott, if that's okay. Is a prolapse bladder genetic?
Oh, that's a whole other hour.
I know, right?
I love prolapse. I love talking about prolapse. I can come back and talk about prolapse.
We talk about pelvic floor all the time.
Yeah, all the time.
It's all connected.
There is a genetic component to prolapse. Prolapse is multifactorial. The number one risk factor, unfortunately, is having vaginal deliveries, but genetics also plays a huge role.
And declining estrogen.
Yes, and declining estrogen. So aging and menopause, genetics, having babies, and then other kind of more modifiable stuff, being overweight, chronic straining with constipation, chronic coughing, heavy lifting perpetually can also put you at increased risk. So yes.
Mm-hmm. Are bladder infections and urinary tract infections the same thing?
Yes, they are the same thing. When an infection ascends up the ureters into the kidneys, then it's called a pyelonephritis. And that's actually very, very rare to have someone develop a true kidney infection. Honestly, on one hand, how many of my patients have gone on to develop that and needed, to be hospitalized because of pain and needed IV antibiotics. So that's very rare, but it happens actually more in pregnancy. When you have a UTI, you're at an increased risk of developing pyelonephritis.
Right. Okay. Interesting. Also, everyone, we have Derek from UTIVA who's in the chat. So if you have product specific questions about anything that Dr. McDermott mentioned, then you can just put your question in there, and Derek will either respond to it tonight or we will get back to you in the next few days in the menopause chicks community. Dee Dee has a good story to share. She says, when I used to work in a nursing home, we had one resident that would sing whenever she had a UTI. It was always our signal to check her urine.
Oh my gosh.
Kind of heartwarming. Okay, I see. And I don't even know if I'm saying it right, but I did have a few members leading up to tonight wanting to make sure that we included questions about IC in this agenda. Whoops.
Yeah, and interstitial cystitis is also another can of worms.
Another big event.
It's another big event. It's so you cannot make the diagnosis of interstitial cystitis or bladder pain syndrome is what it's actually called now, in the face of infection. So it's, if you have infection, then that is excluded because the infection is the cause. So the definition of bladder pain syndrome / interstitial cystitis is having pain with a full bladder in the suprapubic area and in the bladder with increased urgency and frequency that has been present for more than 6 weeks without infection. So that is the International Continence Society definition. So the two they can't happen at the same time.
Okay.
So you can't make a diagnosis of bladder pain syndrome in the face of infection.
And you would have to endure sort of 6 weeks worth of treatment to then get to the other side to determine.
If someone has infection, then their pain symptoms are presumed to be because of the infection. Bladder pain syndrome is a syndrome of pain in the bladder where there is no bacteria present. And that is the definition of it.
Okay. So in this member's case, it's get treatment.
Yeah.
Ask for
treat your infections, get those under control, and then see how your symptoms evolve.
Okay.
Yeah.
Barbara says she was just diagnosed today with a UTI. What is the usual treatment, as in antibiotic? We may have answered that for you, Barbara.
Yeah. So to treat a bacterial infection, you do have to treat it with you should treat it with an antibiotic, especially if you're symptomatic. If you don't have symptoms, you don't have to treat it. That's fine. And actually that's the recommendation, is that you don't treat asymptomatic bacteria in your urine. But if you have symptoms, then usually we treat it, there's kind of a first line standard antibiotic regimen. A lot of people will do. It depends on what the bacteria was and what it was, what the bacteria is sensitive to. But often people will use fosfomycin or nitrofurantoin, or macrobid is the trade name. A lot of people will use a sulfa-based antibiotic. Septra or Bactrim is a common antibiotics. We try to stay away from the Cipros, which are the fluoroquinolone type antibiotics, because there's a lot of resistance that is growing among our communities to that particular type of antibiotic. So the CDC has recommended that we don't treat first line with that antibiotic. So Cipro is not something that you should be getting out of the gate.
Good to know. Good to know. This next question is about leukocytes and nitrates.
Yeah, so leukocytes and nitrates are something that you would see on a dipstick and are indicative of an infection. Nitrates is more specific, meaning if you have a positive nitrate, then it's quite likely that you will have a bladder infection. Leukocytes are definitely less specific. For example, I have patients who wear pessaries for prolapse, and if they do a midstream urine, they will always have leukocytes in their urine because the pessary generates white blood cells from their vaginal discharge that always gets in the urine. So leukocytes, I don't really put a lot of emphasis on, especially if it's a midstream urine. If I'm doing a catheterized specimen in my lab, in my office, then that might be a little bit more specific, but generally nitrates are a good indicator that you have a bladder infection.
Okay. Nadine is asking, what about type 2 diabetes? I'm not sure if she has type 2 diabetes.
Yes, so type 2 diabetes certainly puts you at risk of
higher risk
at a higher risk of infections. And some of the medications, unfortunately, that the newer medications, the Janumet and the Januvia are at a high, patients will have more bladder symptoms and are at increased risk of infection, because the way that these medications work is they dump sugar into the bladder. So, and guess what? Bacteria love sugar.
Wow.
So when those medications came out, we have seen kind of a spike in our UTI diabetic patients, and also our overactive bladder, because sugar in the urine can also be quite irritating and causing a lot of urgency symptoms. So sometimes it's just coming off those medications, and those things can resolve if the family doctor can find something else to treat it with.
Right. So the best prevention strategy, in addition to water, is if you have diabetes.
Oh, good sugar control. Tight sugar control.
Right.
Yeah, is the best way for a lot of things. But yes, definitely with recurrent bladder infections.
Okay. How do we make sure a UTI does not spread to kidneys? I know you touched on that just a minute ago, but.
Yeah, I mean, just treating it, especially if it's symptomatic. As I said, the likelihood of it spreading to kidneys is so low.
Okay.
So I would actually not really worry about that, because it's just so uncommon. So, and again, that's why we say asymptomatic bacteria in your urine you don't have to treat, because we're so not worried about it spreading to the kidneys.
Okay. I like this question from Jody. If as we age, we can have a UTI without presenting any symptoms, should we get checked for UTIs on a somewhat regular basis?
Nope.
So
Nope.
Don't overtest, not required.
Don't overtest, not required. It's like a tree falling in the forest.
Yeah.
Don't worry about it. And I
live your best life.
Live your best life. We were talking about before it started that I was hosting our national conference this weekend, and we had an excellent talk by a urologist from Kingston by the name of Dr. Curtis Nickel, and he is an expert in the field of recurrent bladder infections, as well as interstitial cystitis and bladder pain syndrome. And he's done a lot of the initial work with the UTI vaccine, which is supposedly coming to Canada next spring, although I've been saying that for 3 years. So
okay.
We'll see. We'll see if it actually happens. But he did some preliminary trials with it and has seen excellent results. And so basically the vaccine works. It's a sublingual spray, so under the tongue, that you do every day for 3 months. And the results kind of last 12 to 24 months. And how it works, it's a little bit controversial. And he actually did some very interesting studies where he looked at the urine before and after the vaccine, and the bacterial concentrations of the urine. This is cutting edge. This hasn't been published, so don't tell anyone I'm telling you this. The bacterial concentrations of the before and after vaccine were the same, but the patients had no symptoms after the vaccine. And so the thought is that the vaccine modifies the immune response. So it's more what your body is doing with the presence of this very complex microbiome.
Right.
It has the weekend has shifted how I have been thinking of bladder infections now, because we always are so worried about these bacteria. They're so evil, but it's more how our bodies are responding to the bacteria and handling it, and what symptoms are evolving because of the immune response from our helper T cells. So I think everything's going to change in the next 5 years, like dramatically. So I think in 5 years, we won't even be talking about antibiotics. Honestly,
that is, well, first of all, thanks for sharing. How lucky are we to get this as you come off of that conference? And also, I'm feeling kind of grateful right now, because our general society's awareness of the benefits of vaccination and being aware of how our body responds to bacteria, it's that much higher than it was 3 years ago. So that's going to be good news for all of the
it's so interesting, because you know, in medical school, when you talk about bacterial vaccines, I would have laughed. I'm like, those don't work. Those don't do anything. Why? Like, it's viral vaccines that we've always been learned and talked about. And the thought of a bacterial vaccine that you're ingesting or spraying, like, what is that? But this is groundbreaking. And I think it's a real shift in the way that we'll be thinking about UTIs in the next decade.
Amazing. Are there any concerns about testing, inaccuracy of testing?
In terms of,
Well, I mean, this member's asking
actually,
about
that's a very good question.
testing at Life Labs, but I also know that there's home tests. I mean, what do we really need to know about testing?
So I think, so this comes up, this is a problem for me because I have a lot of patients who are doing these tests all the time. And one hiccup for me is contaminated, that urine always comes back contaminated because, again, you know, it's a midstream urine and it's touching the labia and it's running off the vaginal introitus. And so it's coming back contaminated. And I would say that, like, you know, 30% of my cultures are coming back like that. And sometimes in women, it's just, I can't get a culture. So in that setting, I will always tell patients, come in, I'll do a little in and out catheter, which is, I know it sounds horrible, but it's not horrible. And we just get a clean specimen so we can actually see what bacteria are growing properly. If it's really a question of diagnosis, then sometimes you just have to do that. So, you know, that mixed bacteria, or they see lactobacillus, which is obviously coming from the vagina. So that's an inaccurate test and something that has to be rectified. In terms of Life Lab, all that stuff, I don't know. I mean, I just give my patients requisitions and tell them to go whatever's closest to them.
Good answer. We have quite a few questions about vaginal estrogen and cancer, women living with cancer. Does vaginal estrogen cause cancer? So let's just take a couple of them here. Is vaginal estrogen available in pill format?
Yes. So I usually recommend the pill format one. So the pill format, meaning it's a pill that you put in your vagina. You don't
Yes.
take it orally. And the trade name that's available in North America is called Vagifem, and it's 10 micrograms. And the loading dose is daily for 2 weeks, then twice a week thereafter. So yes, it's a lot better, I think, than cream. For me, I would think cream would be quite messy, but some of my patients love cream.
Yeah.
And that's great. But the tablet is, you know, it dissolves. It comes in these little applicators that are horrible for the environment, but easy to put in. So yes, there is a tablet form.
It's true. And then, as always, we have members who are concerned because they may be cancer survivors, or who may be misinformed about vaginal estrogen as it relates to cancer. Do you want to speak to that?
Yeah, so there's been lots of data around the risk of vaginal estrogen and breast cancer. There's been many studies that have actually looked at the blood levels of estrogen at the outset, and then kind of, you know, 6 weeks to 6 months after starting vaginal estrogen. And there's a little blip. The estrogen goes up a little bit in the first 4 weeks. And that's because the skin is so thin, a little bit gets absorbed because it's like tissue paper.
Right.
But then as the skin gets nice and
so
thick and
long.
healthy, then when it gets nice and thick and healthy, that absorption decreases. So by 6 weeks, the estrogen, the systemic blood estrogen levels are the same as they were pre-starting the vaginal estrogen. So that, you know, there's that data. In terms of if you are a survivor of breast cancer, you know, if you're actively on an anti-estrogen medication like tamoxifen, then I usually put it back on the medical oncologist. All medical oncologists say don't take it, but I will say this is a discussion that you should have with them, especially because you're in the first 5 years after your diagnosis. We know scientifically that it's safe, but this is your life and you've had breast cancer. So this is just something that you should have a discussion with them. When it's greater than 5 years, and they're not taking anything, I'm always quite confident and happy to start someone on vaginal estrogen. And other than that, like, there's no contraindications. If you've had uterine cancer, and if you've had a hysterectomy for uterine or endometrial cancer, you can take it. It's fine and safe to take. So you do not, if you have a uterus and you're taking vaginal estrogen, you do not need to take supplementary progesterone. I know that's in the insert. All of the vaginal products that have the inserts, they're the same inserts that they have for their oral and their transdermal, because it's the companies protecting lawyers protecting their butts. That is why it is there.
Yeah.
And yeah, so it is good for your pelvis. I can't stress that
Your
enough.
vagina loves estrogen.
It loves it. And your bladders love estrogen.
I have to do like a little bit of a tea here. I see there's 99 messages below where we're at. So, kudos to everyone for your great questions, because everyone does learn from one another's lived experience. We're saving the chat. And we will do our very best to respond to these questions in the coming days in the Menopause Chicks community. We are almost at time. I'm going to ask Dr. McDermott one more question, because it's one that came up today actually in the community. And then I have a final question for you about script tips. Valda is asking, my mother is in her 90s. Would you recommend vaginal estrogen at her age?
Oh, that's a good question. If she has symptoms, I mean, if she's suffering with anything, then it's quite easy, and not necessarily like in her inserting or having someone insert it for her if she's unable to do so. But, there's an estrogen ring called an S-string that a lot of my elderly patients will use, because it stays in for 3 months. And then they don't really have to worry about it. But again, only if they're having symptoms. If they're not having symptoms, I wouldn't worry about it. But I'm assuming she has symptoms, or why would you be asking? So if she's having symptoms, yes, that's certainly something that I would start in a 90-year-old if they were symptomatic, for sure.
Yeah, I mean, and if I could turn back the clock, if I only knew what I know now, then with my mom, like dry eyes, dry mouth, like estrogen is our juicy hormone. It helps keep everything in kind of ship shape, and it performs so many jobs for us, prior to menopause. And then we kind of turn to our body and say, oh, by the way, could you do all those same jobs like for another 3 to 5 decades? So it's definitely worth having a conversation with her doctor about the benefits to her, or not, or some alternatives. Like hopefully what you got from tonight is that there are prevention strategies that you can have a conversation with her health team about what would be best for her. Dr. McDermott, one of the things that I really love to do is to leave women with some script tips. Often we go to our doctor's appointment. I started out tonight by talking about statistics of women leaving feeling dismissed and disappointed. And I do believe that one of the gaps we have sometimes is how to have an informed conversation. So I'm wondering if you have any insight for us in how to have this conversation, either with our doctor on our next health visit, or maybe with a loved one this coming weekend.
Yeah, it's funny, like as you were saying that, I was reflecting and I was like, oh my God, what am I going to say? But, be your own advocate if this is happening to you. I think, and even for me, like I have a lot of patients with a lot of infections, and sometimes you get culture after culture, and I might forget that I treated you in September, and then I treated you again in November, and then I treated you. Keep a record and bring it to the doctor and just say, I had this and this bacteria, this and this and then you just show it. It doesn't have to be a long thing, just like bullet points, and just say, this is what's happening to me, and this is a problem. Because I think sometimes we just are like, oh, she has a UTI, I'll just give her another whack antibiotics. And then all of a sudden it's happened every month that year and nobody's really paying attention. So really you have to pay attention and just be your own advocate. I know that sounds horrible as a medical professional, but sometimes these things get lost and so you kind of, it's good to keep track of what's going on in your own body. And then in terms of talking to a loved one, this isn't something that women, especially after the age of 50, have to suffer with. This is not normal. This is not expected. It's not an expected part of aging. And it is something that can be treated. So if you see someone that's suffering, then say this is something that can be fixed or at least dramatically improved. You need to go talk to someone.
I love it. Thank you so much. I mean, what I've been saying, I have a walking group I walk with every morning, and what I've been saying to them is rule it out. Like, I know your mom is maybe in her 90s and she's showing this sign and that sign, and we do have a lot of dementia in our society and we're all aware of that, but just go rule out a UTI first,
Yeah. And sometimes UTIs are a product of something else. Like maybe people have giant kidney stones that are causing these things that aren't causing any other symptoms but UTIs, or maybe they have a giant prolapse that nobody's noticed in the 90-year-old who's sitting in the nursing home, and she's not actually emptying her bladder and she's just getting infections. So maybe there's something else that has to be looked into to make sure that, it's not something worse.
Right. That's so important. And then for talking with your doctor, I always like to just remind us that don't tack it on to the end of another appointment. Don't be like, your 10, 12 minutes are up and then you're like, oh, and by the way, I've had 3 UTIs in the last 6 months. Make an appointment and make it about your bladder health because, well, you deserve to feel amazing.
Yeah. And we have a lot of, in Canada and the US, we have a lot of amazing urogynecologists who have a special interest in this. So there's people who are interested in helping you as well. So if you don't think that you're getting the treatment that you want to be getting from your family doctor, then just say, can I see a specialist in this area?
Amazing. Okay, Derek, I don't know. I haven't gone through all 99, so I don't know if you posted the link, but if everyone scrolls to the top of the chat, I have put the link there for UTIVA Health. If you're interested, I also want to remind you that for your first order at UTIVA, you will get 25% off. And if you're already familiar with the UTIVA products and you want to subscribe so that you never have to think about it, they just come automatically. You're also qualified for 25% off. And thanks to UTIVA for the $100 Visa gift card, as well as 3 months. So the winner of the Visa gift card is Nadine Cherry. And for the 3-month supply of UTIVA products, it's Jody Carrera. Now, Nadine and Jody, I need to ask you to message me. So you can email me at menopausechick@gmail.com, or you can message me through Menopause Chicks on Facebook, and we will be taking care of that. I know UTIVA is busy with a trade show this weekend. Everyone's getting back to in-person events. So we will make sure that you get your prizes early next week. I think that was all for us. I know that so many of you have questions. We'll do our best to answer them. We answer 120,000 questions in the Menopause Chicks community every year. So this is really important. Dr. McDermott, I can't thank you enough for taking time out of your busy schedule for sharing your expertise and experience with us. So thank you on behalf of Menopause Chicks and UTIVA.
Oh, thank you for having me. So much fun.
This is really important. Go have a great night, everybody. Thank you for putting your own name at the top of your to-do list.
Good night.
Good night.